Thank you, the organizers, for inviting me to this meeting. Actually, I'm the first time on this meeting and very much enjoyed with this atmosphere where we are discussing this very important issue, which is the hepatitis C elimination. Next 15 minutes, I will give you, several times was mentioned here my country, and I'm very much proud that Georgia is among these 12 countries which choose this way to eliminate Hep C. The next coming years. We have more ambition. The goal to make this elimination by end of 2020. We will see how we can do this, but at least we are working very hard. And I'd like to thank all our supporters, particularly the members of TAC. We have actually the technical advisory group among this program, which works in Georgia last 4 years. And the first chair of TAG was Dr. Ward. We are very thankful. And now Margaret Herald is the co-chair of this TAG. Last week we had a fourth TAG meeting in Georgia. This is the special mechanism externally evaluate the process which is ongoing in the country and give very important recommendations for the challenges what we have in our work. Everything here was mentioned. That's unfortunately my country is a high prevalence country regarding HCV prevalence. Last study what we did, population-based study together with CDC Atlanta in 2015 shows that active infection has a 5.4% of adult population in the country, which in absolute figures is 150,000. The leading genotype is the genotype 1, then comes the genotype 3, and then genotype 2 in the country. And according to this study, we have as well the information regarding the regional distribution of the prevalence, but not the municipal, the distribution. We have 10 regions in Georgia, and one of the most affected region is this region, Samegrelo-Zemosvaneti region, which is bordering with Abkhazia. Abkhazia is the Ure part of Georgia, but now it's occupied by Russians because, as you know, after the independence, we had 3 wars with Russia, and unfortunately, this most famous territory is currently occupied with Russia, and that's why here the migration is the unofficial migration is high. And in this region, we have a highest prevalence of HCV, HIV, and TB. And that's why later on I will speak about one of our innovation project, what we started in this region. Now we have in each region, we have a prevalence, we have a target, how much people we have to treat in each region, and how many have to identify it actively. This is one of the major finding from our seroprevalence survey. That's the majority of infection is concentrated in males in age between 30 and 50 years old. And I always give the comparison because now we are doing the countrywide screening, and in screening results, we already screened 40% of our population, and screening results are very good in line with this seroprevalence survey. And screening results shows that yes, the major infection is mostly concentrated in age between 30 and here is more 60 years. It means and males, and this is the main target population for our elimination strategy. Here was the questions several times, why Georgia was chosen by Gilead, and we are very thankful Gilead. As you know, Georgia is getting free of charge the medicines from Gilead, and it started in 2015. Why? There are several reasons why. First of all, this is the small country with 3.7 million population with high prevalence and high, political commitment. Actually, twice was before starting this project, the delegation of Gilead to assess the potential of Georgian to go to this, the elimination process. It was supported by CDC Atlanta. Actually, we have very good, since 1995, very good, the collaboration with CDC Atlanta. Atlanta CDC has an office, South Caucasus office in my country, even in our building in National CDC. And CDC was one of the, mediator between the Gilead and Georgian government to negotiate this project. And then they assessed that they we showed that there is a high political commitment generally for health sector. Then we had already some experience treat the HCV. Actually, Georgia was one of the first convince the Global Fund to put in the Global Fund projects in 2011 HIV co-infection treatment by pegylated interferon. And then after in 2013 was introduced in prisons the first free of charge treatment with pegylated interferon in that time. And after in 2013 was introduced the 60% reduction of the commercial price of pegylated interferon. And the laboratory service, in particular the experience in HIV and AIDS treatment, was quite successful in the country, and was decided to have in Georgia this model or pilot project for the Hep C elimination. This is the road. This project was started in 2015, May. Already 3.5 years we are conducting this project. We started with sofosbuvir-based regimes to treat the patients, and since 2016 the sofosbuvir was available as well, and now comes as well the next generation treatment in the country. We started with the 4 clinics centralized, and now we have 41 clinics for the treatment in the country, and decentralization is ongoing, and I will show later on this. And was mentioned here one of the goal, that's the SVR rate in overall treated patients are 98%, and the major the direction now is to go to decentralization. Actually, for today, 1.2 million adult population are screened in the country, unique persons. This is 42% of the adult population of the country, and and 52,000 are enrolled in treatment, was enrolled in treatment. This is the 40% of our national, the elimination goal. What is our national elimination goal? Here, Dr. Tengiz already told, this is according to our national action plan and strategy, which was approved by the government 2016. This is 90-95-95. It means by end of 2020, we have to identify 90% of people living with HCV chronic infection. This is in absolute figures, this is the 135,000 people. 95% of those should be enrolled in treatment. This is 128,000. That's why our goal is to treat for end of 2020, 128,000, and to cure 95%. The third goal is already reached. We have now for today 98% the SVR, and this action plan consists 6 major directions. This is the raise awareness, prevention transmission, identify persons infected with HCV, improve HCV laboratory diagnostic, provide HCV care and treatment, and improve HCV surveillance. Actually, currently, the last 4 years, when this project is ongoing, these programs became like the flagship program in the country for public health, general public health development. Based on this program, we radically have improved in the country infection control. We radically have improved the harm reduction, the services in the country. We have radically improved the blood safety programs in the country. It means this is the driver currently, the general public health development in the country. It is not only the elimination HCV. One of the major, our goal is to screen the full population, which before the introduction of the program, the mandatory screening was only for the blood donors. Now the mandatory screening are introduced for all the pregnant women, all hospitalized patients in the country, recruits, and fast mandatory is for the rest of the population. And screening is one of our major direction. It means until end of 2020, we have to screen full adult population, which is 2.8 million. Currently in unified database, we have 2.2 million screenings. But among them, those 1.4 million are unique persons, and among those 1.2 million are adults and 200,000 children with positivity rate, antibody positivity rate, 8.6%. As you see here, the annually every year the data of screening, the screening number is increasing. The highest positivity rate, of course, we have in 2015, where all the patients knew the status came for screening and for treatment. In that time, the 26% was a antibody positivity rate. Then the anti-positivity rate is decreasing, and as you see in 2018, we have now the 4.5%. And again, the majority is concentrated in this age group. One of the, as I said, this is a driver of the public health development, and of course, major source of the transmission, according to our study, is the injection drug use, and then comes history of blood transfusion. During the last 5 years, dramatically was increased the number of screened of injection drug users in the country, and as you see as well, the positivity rate already in drug users goes down. We are screening together with 14 harm reduction centers here, and the Global Fund is very much engaged in this process. By Global Fund, we purchased 6 mobile units, and 80 harm reduction workers are working with this in this system. Regarding this, we are doing, of course, this micro-elimination process in different, the most highest affected groups, like the TB patients, HIV-infected individuals, hemophilia patients, OST program beneficiaries, dialysis patients, war veterans and their family members, and one column is not here, which is in villages. We are doing this summer, we did a pilot in villages, 38 villages in the country. We are the village, the governors are enrolled in process that they are helping us to identify, to screen everybody in village and to link to the cured and all positive patients. All positive, yes, individuals. As you see, the highest positivity rate we have in the OST program beneficiaries, as well in HIV and hemophilia patients. This is the map of the Georgia with treatment providers. As I mentioned, we started with the 4 treatment sites in Tbilisi, and these are our referral clinics currently. And currently we have 41 sites, including the 8 sites in the primary healthcare. And the enrollment primary healthcare is one of our major direction now. This is our, the Cascade Hepatitis C Elimination Program, which shows that now in database we have 102,000 HCV antibody positive people. Among those, 75,000 went to the confirmation testing, and confirmation we are doing by core antigen and by using core antigen as well, the PCA methodology. And now we are going to this care point with this finger stick, using this methodology for the PCR technology. And one of the major challenge what is in our program that we have in our database, 26,000 now HCV antibody positive individuals who did not went to the confirmation and to the treatment further. And to find this with the active finding mechanism of our epidemiologists and public health doctors is our major challenge now, and I think we have to solve this problem in next year. The same out of 64,000 PCR positive, the RNA positive patients, also 13,000 did not went yet to the treatment. That's why this is one of the major challenge we have to advocate very much and to, to invite those to this next process. We started, as I mentioned, in 2015, the treatment with sofosbuvir, the base regimens. Then in 2016 was a major inflow in the patients rate enrolled in the treatment. While this, we removed all this, the criteria for enrollment, and the Harvoni was introduced in the country. And since this year, we started decentralization process, and in December came already from the Gilead next generation, the velpatasvir plus sofosbuvir. This is, one of the most innovation, what we are going to decentralize the treatment. As I mentioned, we started with 4 clinics. Now we have 41, and next year in each municipality, and we have 65 municipalities in the country, in each municipality at least 1 treatment center should be. And I hope that the next 6 months we will reach this goal. And the next, the innovation is 3 diseases under 1 umbrella. What we are piloting in this Samegrelose-Mosvaneti region, where we have the highest prevalence of HCV, HIV, and TB. By the support of Global Fund, and we engaged Global Fund, and we are very thankful to Global Fund, because, this was always discussed even yesterday, how could we engage the Global Fund in the process. And we had a long-term negotiation with Global Fund. Actually, my country is a Global Fund recipient country. We are getting the grants from Global Fund for HIV and TB since 2003. And by the support of Global Fund in this region, we have trained 454 doctors and nurses of primary healthcare nurses and doctors, and started in April this year screening for these 3 diseases, HIV, TB, and HCV, on primary healthcare level, all populations. And we already screened in this region during 7 months 90,000, around 85,000 of population, and this twice more than was before, after starting the program. This is also interesting that here we make the incentivized the primary healthcare physician. The local government, this is they like the collaboration with central government, Global Fund, and the local government. Central government pays for the test systems, and the local governments makes the incentivization of the doctors and nurses. They pay each, for each screening around $2, which is around $1 for each screening, and this incentives works quite well. It means this is very good support for the rural doctors, and dramatically has increased the screening in this region and identification of the new cases of TB, HIV and TB we are screening with rapid tests. HIV and HCV we are screening with rapid tests, and for TB we have a special questionnaire. And the positives they are referring then to the specialized clinics. This approach we have discussed during this September. There was a high-level meeting in New York on TB, and there was a site meeting organized by WHO and 14 UN organizations. They signed the joint memorandum to have this integrated approach for these 3 diseases, and particularly on the primary healthcare level. And the Georgian this experience was presented by Minister Sergeyenko and by me during this meeting. What's the findings and what we have to do next 2 years? Next 2 years will be very hard for our program. As I mentioned, we are 2.8 million adults population in Georgia, and totally currently are 1.2 screened. And for next 2 years, 1.6 million we have to screen. Theoretically and practically, this is achievable in the country. More difficult is here that we have to, to identify 135,000 RNA positives, and currently under the treatment is, it means 52. It means half of those are left to identify and to enroll in the treatment, which is very, very difficult because the positivity rate goes down, and we are making the active identification, but quite challengeable. For this, what we have to do? First of all, we did in this year the barrier study. The first barrier is still the awareness, lack of awareness in the population. And we have to strengthen and to scale up very much the awareness of the population about this program. And yes, we are speaking a lot of TV, we are sending the SMSs, but it's not enough. We have to, and I'd like to ask all our partners to give the advice how to do. Then, of course, to intensify the routine screening, strengthen the involvement of primary healthcare sector, implementation, this program, what we are doing in one of the region countrywide, and intensify enrollment of harm reduction more and strengthen the follow-up of this. These are our, the major, and as a conclusion, I will, from this one, I will not read, but I will say only one. This is the program which is now the driver, the full public health system in the country, and particularly the integrated approach, HIV, TB, and HCV should be considered as one of the major, the approach, and the decentralization and to go to the primary healthcare level for the elimination is a crucial one. And some lessons we have already, with pleasure we will share with what we have already, we can share with you. And once again, thanks many to CDC, Gilead, World Health Organization, because with WHO, Euro, and WHO headquarters, we are working very hard. Particularly our strategy is based on the WHO approaches to LIFER. The ECHO is working very hard in Georgia. Now we have extended ECHO even for TB, World Hepatitis Alliance. I'm very thankful because we became one of the part of the World Health Alliance, the No-HEP movement, and all the TAG members and HCV elimination program providers. Thank you very much.